Hello, my name is Dr. Alison Graham and I'm lead clinician at the National Spinal Injury Centre at Stoke Mandeville Hospital in England, in the United Kingdom. What I would like to talk about is spinal cord injury, the lifelong care as it occurs in the United Kingdom. We have been providing spinal cord injury services since actually 1944, and in fact today of recording is our 78th birthday. Services began in the 1940s during the Second World War. Initially, the inpatient unit was set up, and this picture shows the actual hospital of that time. What our founder, Sir Ludwig Gutmann, found was that it wasn't enough just to look after people in the inpatient stay. In order to have people living in the community and actually living after spinal cord injury, he needed to look at how people were going to be looked after once they left the inpatient facility. So work was commenced to improve both the quality and the quantity of life after the initial inpatient promises and chances that his care provided. Within the United Kingdom, which consists of 4 home nations, there are 12 centres across the islands of Great Britain and Ireland. However, only 8 of these units are in England, and the funding for the 4 different countries is completely different. Our service is to extend from day 1 of the injury or insult to the cord, and it expands throughout the lifespan. And so it is sort of quickly known as the cradle to the grave service. The service is free at the point of care. It's funded entirely by our National Health Service, which of course is not completely free, but it is provided by income tax and other forms of taxation. The care pathway within the United Kingdom, within the health service, exists for the pre-hospital care, which is delivered by the ambulance service, of which we don't have any direct input to. Over the past maybe 15 years, there has been an awful lot of work where the person with a major trauma is taken to a major trauma centre rather than to a smaller hospital. This has been shown to improve outcomes and particularly reduce mortality after major injury. And so a lot of people who sustain a spinal cord injury for whatever traumatic reason will be admitted to a major trauma centre that we link in with. Once a person usually has had stabilisation and fixation, they will then be transferred to their local spinal cord injury centre. And it's at that point the lifelong care will begin. Our service does cover patients with traumatic and non-traumatic injury or insult to the cord. What we really want to talk about at the present is what happens after discharge. During inpatient care, we have multidisciplinary input, and what we're looking to do is to continue that at the appropriate time after discharge throughout that person's lifetime. We use the domains of rehabilitation to ensure that comprehensive follow-up is followed out of hospital and into the community, wherever that person chooses or is placed after hospital discharge. What we're looking to do is to promote the optimal outcomes that we feel we've established during their admission, but recognising that a lot of recovery and improvement occurs out in the community. We want to reduce mortality and morbidity and thereby improve the quality and quantity of life after spinal cord injury. When we actually thought, what are the principles? We know what we've got to do, but what do we aspire to do well? And as part of a high quality service, what we wanted to look at are the principles of the service, which is covered by the acronym STEEP. We're looking at safety, providing the best service for patient safety. It's got to be timely. There's no point seeing somebody long after a complication has occurred. It's got to be efficient to make best use of our resources. It's got to be equitable. We see people from all over the country. We see people who have been injured or have had a non-traumatic And we have people with mental health problems, learning disability, and all ages. And they're all equally entitled to access our service. And we've got to be effective. We've got to know that what we do is best practice. It's going to make a change to the person's life. And it's patient-centred. It's got to be based on what the patient needs. And that very much goes back to what the principles of Sir Ludwig Guttmann were. It wasn't a case of saying, we've got surgery, you can have the surgery. It was a case of saying, what does this person need to do well and to live well? And adapt the service and bring in the people around the patient to develop the service. On discharge, we tend to see the person usually around their 6-week post-discharge. Traditionally, this would have been done in person. During the COVID pandemic, a lot of this has been done through telehealth. We then would be reviewing the person initially at 6 months, and then we try to attempt an annual review for life. We do have direct access to the unit for specific problems, and we've built up an outpatient department and a telephone and video consultation service that people can access us quickly. They don't have to go through their general practitioner, but we do tend to work in liaison with the general practitioner. The general practitioner, again, is provided by the health service. They are working in the local towns and villages. They are responsible for the day-to-day care, along with the teams that work with them. However, it's been noted that a general practitioner, despite being trained in many aspects of delivering medicine, is only likely to ever have one person with spinal cord injury in their professional lifetime. So there's no way that they're going to be able to respond to the nuances of spinal cord care. So who performs the review? Initially, when Sir Ludwig Guttmann started, it was almost entirely medical staff. But one of the things that he was involved with was growing the team round about him. And it's something that we have continued to do. Over the years, we have added a physician associate who work with the medical team to review the medical aspects. However, we're also looking at reviewing what the person needs. So often it's physiotherapy, occupational therapy, nursing, psychology. We also have dietetics within the department. And it's essentially to look at it based on what the physiology has altered that we then have to provide the particular medical care and services for. Some patients may only ever see the medical staff when they return. Other people may spend an awful lot more time with the nursing staff or with the physiotherapists. So though we have an open access, it is triage to see who does the person need, and then the ongoing review occurs after that. I should say at the present time, we have not got psychology involved. It's in a plan to increase going forward. So what are our basics? Essentially, the annual review will cover bladder, bowel, skin care, pain, mobility, equipment, comorbidity and medication. And obviously how much is spent on these particular areas very much depends on the presenting problems. We've done a lot of work to try and standardise both the question taking using healthcare questionnaires and recording what information is required. Traditionally, a lot of this was done by the doctor. What we're now looking at is having other healthcare professionals do the screening tools, and then only if there's a particular problem in any of these groups would they be referred either to the medical staff or to the specialist nursing or therapy staff for the individual needs following the triage form. As part of this, we will look at annual review, particularly of ultrasounds. We will look at MRI, particularly if there's been a change in neurological level. But as I said, this is our basic screening tool that we then base how we're going to follow up in the medical and other therapy input. Over the years, we have seen an expansion of the non-medical clinics. So we've really had to respond to what people actually need. We have a lot of patients who will be returning for bladder management, Often we find that a lot of catheter care, if it's complex, cannot be managed in the community. And although we will teach people and their carers to perform catheterization or changes of suprapubics, etc., the ones which are complicated or very difficult to do will return to the centre. Bowel care is something which constantly seems to change as a person ages, and that's something that we will tend to bring people back. The specialist bowel clinic will either cover day-to-day problems with managing incontinence, or it will be a referral on to gastrointestinal surgeons if surgery is required. For skin care, we will continue to teach people the best way of looking after the skin, but one of the things that we've been looking at is the advancement of skin practice beyond pressure ulcers and looking at both vascular, venous and arterial changes, which we are seeing particularly in patients as they age and those with comorbidities such as diabetes. Now, the new clinic that we have opened recently is our preoperative assessment. We've been trying to reduce the amount of time people return to hospital for procedures and to ensure that we don't waste any clinic time or theatre time by ensuring people get the best fitness to be forwarded for surgery. This is in addition to the therapy clinics, which includes physiotherapy, orthotics and occupational therapy. We will be reviewing people's splints and equipment throughout their lifetime. We also have pressure mapping clinics for review of seating and posture. And we also have a weight management clinic run by our dietitian, and that's been very successful to try and compensate for the increase in obesity that we are seeing with patients as they age and the difficulty they have in accessing, particularly weighing machinery out in the community. So while almost all the patients will be seen by the previous therapists and healthcare professionals during their lifespan, we also have specialist clinics that we run. These are often surgeons and other medical personnel who have roles in other parts of the hospital, but they are involved with us for the ongoing lifetime care. For the urological surgeons, often it will be insertion of suprapubics, or it may be stone removal, and also starting to look again at the specialist clinic for sacral anterior nerve root stimulators. We've been working a lot with the gastrointestinal surgeons. A lot of that has been because of patient request, but one of the things that they have wished to be involved is after a lifetime of maybe trying to manage their bowel with a neuropathic bowel routine, they've got to the point where they've wanted a colostomy, and so we've been involved with that. Our plastic surgeons work alongside us for the patients that we cannot manage in the conservative complex wound clinic, or if there is particular problems with osteomyelitis, we may involve either plastics or orthopedics. So a lot of our plastic surgery is involving flaps and other repair of pressure ulcers. Over the past 10 years, we've seen an increase in the upper limb surgery that our plastic surgeons have specialised in. And so we're now seeing more surgeons who will only do plastic surgery for wounds, or they will concentrate on upper limbs. A lot of that will be people that we will continue to see as they are sort of followed up, and it may well be that they've not had the recovery that we've hoped, and so they will be forwarded for tendon transfers or nerve transfers at different points post-injury. Orthopedics are closely working with us, although we have Botox and spasticity clinics. We also find that there is still a need for surgical intervention for some patients. Unfortunately, those that develop osteomyelitis may often end up with the orthopedics. The other problems we have can be sometimes the initial surgery that was done to stabilise the fracture. There may be metal fatigue or whatever. We also have a very large paediatric practice, so scoliosis work is part of the orthopedic follow-up. As we have a very large practice, we have approximately 5,500 patients with spinal cord injury that we are responsible for their ongoing care, and a lot of those are females. We found it was easier for us to actually provide the gynecology and early pregnancy work along with the obstetricians and gynecologists, mainly because it was very difficult for other places to establish enough clinical practice to actually make a difference and to be involved in the shared care for gynecology and pregnancy work. So it's something that we have done for a long time, and that can be from cervical smears to following a woman throughout the pregnancy. Because we're a large unit, one of the things that we have been able to do is to develop both our paediatric services and also our adolescent and young person clinic. One of the things that we had found very similar to other long-term conditions is that paediatric care, where the child is often brought by the parent or guardian, children will attend religiously and we have a very good turnout. Once the young person goes into adolescence and young adulthood, we have found that they don't tend to keep up with preventative care. So what we have done has been a two-pronged approach. We have set up a special clinic where they are still seen by the staff that come from paediatric and adolescent services, but it is based in the adult department. And also as part of their ongoing rehabilitation and follow-up throughout childhood, we have instituted the Ready Steady Go programme, which was actually started by a paediatric practitioner in the University of Southampton. And it's a planned gradual follow-up, changing the responsibility for care from the adults and the professionals to the young person, so that by the time they actually leave paediatric services, they are ready to be followed up by adult services. It's something which we've not been able to follow up for a long period yet, but when we initially had an adolescent service and an adult, we found it very difficult to keep the young person in regular review, and unfortunately would then turn up at a much later date with problems and secondary complications that we wanted to lose. When we started planning for our future and how we were going to change, we had lots of ideas, and then the COVID pandemic really has hit over the past year for us and has significantly impacted on our service. One of the good points of it is it really has pushed teleconsultation for follow-up review within the UK, probably forwarded it by about 10 years in 10 months. So that we are now able to see people over a far greater period and far greater distance throughout the COVID-19 pandemic, despite restrictions on lockdown and travelling. But the patient advantage is really the reduced travel, not having to significantly impact on getting up early, getting the carers, getting their bowel care. The reduction in travel and the cost of travel is significant. We're still able to see that most patients for most things, and we have a far quicker turnover through in clinic. The disadvantages really has been that it does feel artificial. There's no touch. You really do need the video aspect of it. It does not work with telephone follow-up. And we're finding difficulty with regarding screening for radiology in particular. And we've had to look at how we can actually follow up people not in our centre, but with radiology imaging closer to home, and also getting blood tests in order to fulfil our annual review for both radiology and blood tests, as well as physical examination. So I think there's good parts of it, but there's parts of it that really have altered our service, and we need to continue to review what particular problems we may not be picking up on. During this time, we've had an opportunity to look at how we want to do things differently. We've got a lot of patients with a very long service record, people who've been injured have been attending us for 1 year to those who have been attending 40, 45, 50 years. We need to look at how we can take the service to where our patients are. And we identified that some of the patients who were not turning up for follow-up, it was because they were not in their own home, they had moved out of area, which wasn't a problem because we could refer to another spinal unit. But we needed to look at what was happening to patients who were admitted to nursing homes and also patients admitted to other hospitals. Again, because there's not the knowledge and experience in other places for looking after people with spinal cord injury. So what we've been working is what we call our wraparound service. We have our acute outreach, which sees people in the trauma centres. We have our inpatient care. We have the outpatient, but then we have this team that wraps everything around that to ensure that none of our patients are left out of the lifetime follow-up. A huge part of what we're able to do has got to be underpinned by providing education. And in particular, one of the large parts of spinal follow-up and outpatient care is all about lifelong learning. What you learn about your body when you're first injured is not going to last you a lifetime, particularly if you're young. So though we teach during the first admission, we felt it wasn't enough to continue over the lifespan. So therefore, we're working on our NSIC Online, which is a web-based education resource for patients and families to keep up to date with current practice, to ensure people keep in touch with the centre and make sure that they are able to keep on participating. Very much leading straight on to the self-management. We want people to be in charge of their bodies. They are not often ill with it, they are living with a chronic condition. So it's incredibly important that they learn to be the specialist for their own body. And this is part of what we call supported self-management, which is part of our National Health Service long-term plan and commitment to make personalised care business as usual across the health service. And it's about identifying what people need to know in order to keep themselves well. We then work with the person to ensure that we build up their confidence to manage. It can be very practical, from things like managing to take a urine specimen if they think they've got an infection, to health coaching, peer support, and essentially changing those skills and knowledge as the person ages. How effective is our service? I think one of the sort of large ways of working out has been the improvement in life expectancy and quality of life after injury, and how it is maintained not just by a one-stop service for the initial admission, but keeping people alive. We also have a thing called the Friends and Families Test, where everybody who's admitted to our service is asked to give individual and quick, timely response to certain questions, which is sent out by our National Health Service. This allows us to check what we're doing well, where we've not been particularly user-friendly, and alter and adjust where we're going forward in the future. Our strengths for us is the size of department allows us to specialise, to provide the particular clinics that people can come. This allows our staff to develop and allows our patient to get up-to-date care. We also use the research department to shape development here. One of our weaknesses is that we do actually cover a large geographical distance. And so if somebody has a wound in particular, daily review, etc. is just not possible. Big opportunity recently has been telemedicine and how we can more effectively manage more people in a shorter time. The threats that we're finding particularly with that is fragmented care. Previously the person would come and get everything done in the one day. We're now finding it much more difficult to see someone, have imaging, have blood tests, and hopefully once the pandemic for us settles, that will improve. I would like to thank you for the opportunity for allowing me to give a quick talk. Some of the photographs have shown our department. We've been lucky to have a garden endowed to us recently. Our outpatients are obviously not seeing much of this at the present time because they're attending mainly virtually. As I say, I would really like to thank people for inviting us, and I welcome any questions. Thank you.